Good morning, this is Mrs. Lewis, and I am going to give you a video for chronic kidney disease. And this is mostly nutrition. So what I would recommend is making sure that you have watched your lecture video first, and this is just a supplement to help you kind of understand a little bit more about the nutrition and the progressive disease that chronic kidney is. So this is renal nutrition for chronic kidney. Now what I want you to do is take a blank piece of paper and draw a circle and try to make your separations or your pie chart like this one. So draw you a circle and then create the lines that I have here. And this will be interactive for you because research shows that if you write something down, then it sticks with you better. And I'm going to say that again. Research shows that if you write it down, you are more likely to remember it. So please write this down. So this is what you're seeing, just a circle with some lines. Now the first thing I want you to do is label everything. CKD, the first one. And then I put ESKD here, or pre-ESKD, so the end-stage renal disease or end-stage kidney disease. And you often will hear it referred to that even when they're on dialysis, but you'll also hear it referred to that as they get near and closer to dialysis. The kidneys, the glomerular filtration, starts to decrease. So when it starts to decrease, you are going to see some symptoms of not only fluid accumulation, but you're also going to see those symptoms of uremia and the buildup of waste in the body as the kidneys deteriorate and the GFR goes down. So that's why I put pre-ESKD, because it could be, anywhere between, the GFR could be anywhere between 60 to 15, because once it's 15, they go on dialysis, 15 and below. So I think of it, and every person's different. So one person might not see symptoms with a GFR of 40, whereas other person might see a few symptoms. Most will all see symptoms once the GFR drops down to 30. So let's finish labeling here. We've got hemodialysis, or HD, and peritoneal dialysis is PD. And over here I did write the GFR. So usually with CKD, just chronic kidney, your GFR is less than 60 for 3 months. And like I said in lecture, or like I've said before in lecture, the GFR, our GFR, when you get your lab work, it'll say something like 60 or greater than 60. And that is the ideal. Now, typically GFRs are more than that, but in order to actually figure out an accurate GFR, you have to use the formulas, and they talk about a little bit about the formulas in the book. That is just a good to know, and especially if you specialize in renal, you'll need to know those. But just know that to figure out the GFR exact, then it's a special formula. But for the need to know purposes, GFR of less than 60 over a 3-month period is usually your diagnoses for chronic kidney disease, okay? So that's something to remember. And then we've got a GFR of less than 15 usually once they go on dialysis, or they're going to need to go on dialysis. And that's not necessarily a have to. It's usually when people start having that accumulation of uremia as well. That'll be a need to go on the dialysis. So it can be both, and it just really depends on the doctor and the patient before they actually go on dialysis. But typically it's less than 15 or less. And then I wrote up here the GFR 30 to 60, and that's that period where we're conserving the kidneys, but the kidneys are failing anyway, but we're trying to do everything we can but they're in chronic kidney disease, so it just, it decreases over time. So that's why I wrote that up there. And then I also wrote on this ESKD that the GFR varies. So it could be 40, it could be 50, it could be 30 during this end-stage kidney disease. It could be 15. So this varies. Now, I wrote glucose checks, and I wrote it on everything because even with your chronic kidney, they have altered carbohydrate metabolism, right? So they might have mild to moderate hyperglycemia. They might have hyperinsulinemia due to the impaired glucose metabolism. I mean, think about it. If the kidneys are not performing optimal, then they're and you put insulin into your body, then with like a diabetic would, then the kidneys cannot excrete the insulin or get rid of it. So your diabetic might need less insulin. But there is an altered carbohydrate metabolism because the insulin depends on the kidneys for excretion. And when they're on peritoneal dialysis, the peritoneal diacylate is full of glucose. And, it's different amounts of glucose depending on the person's size, but that's how the ultrafiltration takes place, is with that glucose diacylate. So they definitely will need glucose checks on peritoneal. So that is why I wrote glucose. So let's get into the nutrition. So with chronic kidney disease, the protein in our body will build up if you eat a lot of meat, and protein turns into a nitrogenous acid, and if the kidneys are not able to buffer off those acids, or those hydrogen ions, then you're going to see some problems or some acidosis. So they're going to typically try to have a decreased protein diet, but we need protein. We really need protein for our metabolic purposes, for healing, for several things. So in the body, so they need protein. So there's a fine balance of protein. There's a fine balance, and so it'll be individualized. They'll be getting blood work. They'll be checking their total protein, their albumin, and they may have to take some supplements such as Nepro. So there's a balance there, because we don't want them to be emaciated. As you know, if you don't have enough protein, your body will start eating your muscle mass as protein, and then your patient will be extremely emaciated. So protein, typically a decreased protein, but again, it depends on the balance and patient specific. And they may be on a DASH diet, cardiac or a renal diet, depending on what, are they diabetic diet or a diabetic and a cardiac diet or a renal. So the thing is, with a chronic kidney disease, most of our patients are diabetics or cardiac, hypertension, cardiac disease. That is the majority of patients. So in order to preserve the kidneys, these patients really need to be compliant. That is part of our conservation therapy. We're trying to conserve as much of the kidney as we can, trying to keep it from deteriorating and from that filtration, the glomerular filtration going down. So during this time, we are trying to conserve those kidneys. Water's not generally restricted, because again, their filtrations, the kidneys are filtrating, they're just not as well. Now, when it gets lower, it might be some restriction, and we're going to talk about that when we talk about the pre-end stage. So water's generally not restricted at first. And the thing is, I've already talked about the conservation of the kidneys, but lifestyle changes. Lifestyle changes are so important. It's a mindset. we've talked about before how people say, I'm on a diet, I'm on this diet, I'm on that diet. Well, it's not a diet. It's really a lifestyle change they've really got to get on board with. Now, sodium, I wrote NA on the side over here. It says NA depends, and it really depends. Because if you've got a patient that's got some heart failure with a lower EF or ejection fraction, then yeah, they're going to be on a sodium restriction. So that really depends. That's patient specific as well. So just remember that. So let's talk about the ESKD. Fluid allowance depends on output. And that is because it depends on if their kidneys are getting rid of the water, right? So that depends on output. And then calories are 30 to 35, and this is straight from your book. There's a chart depending on what edition you have. If you look through the kidney failure or the chronic kidney disease chapter, then you'll find the chart. But there is a nutrition chart that really is very similar to this. There might be a number or two off, but it's pretty much the same. So calories 30 to 35%, the protein, calcium, potassium, and phosphorus are all patient specific. Again, we're going to be drawing labs. We're going to be assessing the patient and what they need. Sodium, again, 1 to 3 grams per day, because what is sodium? Water follows sodium, and we don't want them to get into trouble. So again, sodium will probably be restricted once that GFR starts dropping, because water follows sodium, right? Then iron. So if they get to the point where they need the epoetin therapy, then they're going to need iron, right? So if they need the epoetin therapy, then they need iron. And you need to be familiar with the names of the generic names of the epoetin therapy. And then let's look at hemodialysis. Hemo, that's where they use a dialyzer. The patient goes in 2 to 3, 4 times a week to the center, to a community center or a clinic, and they get dialyzed. The blood goes through tubes and through a dialyzer, and that is where the fluid and the waste are removed through that ultrafiltration process. Now, water restriction is going to be usually 24-hour output plus your 600 of insensible losses. And you say, what is that, 1,000? It says 600 to 1,000. Well, it can be more depending on the person's size, depending on what if they have a trait. Well, they're going to have more insensible losses, right? So think about, for memory purposes or for testing purposes, just remember 24-hour output plus 600 is your insensible losses. And then protein. You want 1 to 2 kilograms per day, and that again is patient specific. Potassium is patient specific. Now, I wrote it down here. I wrote protein down on the peritoneal as well. This is straight from your book. Just a good guide. So with peritoneal, they can have a little more protein. In fact, protein's not as restricted. So because you're going through, you're using their gut for their dialysis, and they just, they have a lot less restrictions. They have less water restriction, less dietary restriction. So remember that, and that's why I wrote it there, so we could show the comparison. They can have more protein on peritoneal. With hemo, again, they're going to be on phosphorus supplements, because they phosphorus binders, and then they're going to be most likely on calcium and vitamin D supplements. A lot of times the phosphorus is the calcium. So you've got calcium acetate, calcium carbonate for your binders, and they may go on those even before they go on dialysis. So keep that in mind. But they need they say usually they're limited to about 1 gram a day of meat and dairy. Mostly dairy. There are a few meats that have some phosphorus, but just remember, if you remember dairy, you will be good. The and then I put supplements as well. And when I said that, I meant like your vitamin D, your calcium. They do have phosphorus binding agents that are calcium free for those patients that have the soft tissue calcifications and the CKD mineral bone disorder, right? So they do have some that are calcium free. Those are like your lanthanum and your sevelamer, and I may not be saying that right, but those are calcium free binders. And I wanted to highlight potassium because what of all the electrolytes can kill you? Potassium, because of the risk for dysrhythmia, right? So potassium is definitely patient specific, but you need to make sure you remember some of the high potassium foods. Some of the books have potassium foods. You can look it up, you can Google it, foods that are high in potassium, because that's something we've got to teach them. We've got to teach them that they cannot have a lot of potassium foods. This is possibly end-stage renal and possibly hemo. You know, it's really patient-specific. If they're more prone to having hyperkalemia, then they're going to have to be careful, because we're trying to help them and teach them so that, they don't have a dysrhythmia and die. So know your calcium, know your potassium foods. And I just wrote a few here: bananas, avocados, melons, orange juice, prunes, baked potatoes. All of those are high in potassium, and they have to really limit those. I've told a story many times. I've had a patient that came in extreme distress, high potassium, chest pain, and she had eaten watermelon on 4th of July in between. So she dialyzed on Tuesday, 4th of July was on Wednesday, and she went into that because she ate so much watermelon. She almost died and had to come into the hospital. So it can happen. It can happen, especially if they're if they're not putting out much urine or any urine. There's nowhere for it to go. So just remember that, and remember your medicines that will remove potassium besides dialysis. Which one is it? It's your sodium polycystyrene sulfonate. So that will remove potassium. But with these patients, often they really just need to be dialyzed, especially if they're already on dialysis. They might, if they are having a dysrhythmia, you don't have them on a monitor, you need an EKG. You need to look at the labs, to think, what is going on here? Do they have a high potassium? That should be the first thing you think about. If you don't have that patient on a monitor, you need to be thinking, is this dysrhythmia? Could this be hyperkalemia? So that is something to think about. And also the sodium substitutes. Now there's some that don't have potassium in them. I think Mrs. Dash is one of them. But some of those no salts, they have potassium. So that's something to know and to teach. Another thing is some of the medications like magnesium and aluminum preparatory medicines. They can, they're not excreted. So if your patient's taking that stuff and they're on dialysis and they can't get rid of it, then they could get into some trouble. So we have to explain and teach about that as well. Again, the same thing here, the iron supplement if on epoetin therapy, and they're getting blood work regularly, and often your dialysis patients just kind of run low hemoglobin. That's just something that they do because the kidneys, are not able to do their job with erythropoiesis. And the end effect of that is some low hemoglobin, not to mention if they're on renal hemodialysis, then they're losing some blood through the dialyzer every week, through the tubes every week. I mean, we try to rinse it out with a saline rinse afterwards, but there's still, some lost in that. And then peritoneal, water and fluids are not restricted. Yay. So that's why a lot of people like the peritoneal. Not to mention, they're more mobile with it. They don't have to go to a clinic 3 or 4 days a week. They don't, they can live their life. They can travel. So a lot of people find peritoneal to be optimal if they're active. Potassium's not restricted, but again, they do need those glucose checks. And then the protein, they can have more protein. They, it's usually not even restricted. It really just, it depends on the patient. But calcium and phosphorus, patient specific, they still are going to need those phosphorus binders, and they're still going to need that iron supplement. Because if you think about what the kidneys do, there's still that the kidney CKD, mineral bone disorder, and there's still the erythropoiesis that's not occurring because they're still in kidney failure. So they're still going to need probably a epoetin therapy. So remember those drugs, know those drugs. And the last thing I want to talk about is just know your benefits and complications of peritoneal. I talked a little bit about the benefits, and know your complications. If you haven't read that part in your book or listened to the lecture, then make sure you listen to that. A lot of times with peritoneal, they can get hernias, they can get back problems. Think about all that fluid sitting in your stomach, they're not taking really good deep breaths, and so they're not getting a good lung expansion, so they're more prone to pneumonia and stuff. So know your complications, infection, know signs and symptoms, because infection's a huge thing with peritoneal. They have to be meticulous aseptic technique while they're doing their dialysis. And so they have to be teachable. They have to understand the process and the importance of being aseptic. So know all of that, and know the benefits and complications. And I'm gonna stop here. I think this is a good review. But like I said, I hope you've already listened to your lectures, because you might be lost otherwise. And good luck to you, and I will see you soon.